Next, Athena Poppas is joined by Dr. David Cannom, professor of medicine at the Geffen School of Medicine at UCLA and director of cardiology at the Good Samaritan Hospital, both in Los Angeles, California. They discuss protagonists. Athletes with an ICD should be able to participate in sports. Contemporary debates on ICD therapy.
Dr. Cannon, thank you very much for joining us.
Well, thank you. Good morning.
Let's talk a little bit about what the background for this is. The 06 guidelines, both ACC and ESC, had some consensus statements which really advised against doing any vigorous activity short of bowling or golf for people with ICDs, and I think it prompted a study. But tell us a little bit about that.
Well, you're right. In the last 15 years, I think Rachel Lampert and certainly Brian Oslansky and I, who were responsible for this study, have all been seeing more young athletes with reasonably preserved ejection fractions or normal ejection fractions who have ICDs in place, who want to participate in aggressive athletic formats, whether it's in high school, college, or beyond. And the impediment to their doing so has often been the very conservatively written Bethesda guidelines that were published in 2005 that limited athletics to the various sports you talked about. And the idea of running or participating in basketball was simply not permitted in these guidelines. These were experiential statements based on the author's best intention. I don't think they had an axe to grind. They just simply didn't know.
Which is what science should do, is take the data we have and realize there's a gap in knowledge. And so what did you do with that? You realized that you had a number of patients who were actually out there exercising. So you wanted
Well,
to
we had gone
data.
through this laborious process of being turned down by so many schools that we finally decided, let's get some data.
Good.
The first thing we did was to do a survey of the HRS, Heart Rhythm Society members. We had a very good return rate, asking them, do you have young people in your practice who are doing sports that are in violation, technically, of the Bethesda guidelines? And the return rate was in the 70s, and we had 50% say that they did have athletes who were doing more than they might have if they'd followed the guidelines strictly.
So tell us then about the 2013 circulation paper, the registry you did.
Well, the registry then became a real labor of love because we quickly were able to raise money to support this from industry. It was a different era than it is now. And we wanted to enroll as many consecutive patients as we could from 41 practices in the U.S. and 18 practices in Europe, and then patients who read about it on the internet and wanted to be part of it. And thanks really to the hard work of Rachel Lampert, we were able to enroll a cohort of 372 athletes, much younger than any other series that's been presented, who were actively engaged in sports, who had their rhythms well controlled on beta blockers typically, and who were either doing what we call competitive sports in a league or in a formal format, which guided their athletic careers, and then followed them over the years to see what kind of trouble, if any, they got into with this very liberal approach to their athletic lives. We screened them to make sure that it would be safe. That is, most of them had full treadmills before they got into the study.
So that's important. Okay.
And their mean EFs were in the 60% with some range, but nothing below 50. And most of them were on beta blockers.
Good. And also in this paper, you had a range of younger people, so it was age 10 to 60, and the average or median age was under 40. So a very contemporary group.
And a lot of these kids were playing in high school, college, and beyond. And the people over, let's say, 25 were elite runners. They were elite athletes.
Fantastic. And so you had two questions then, both to look at the safety. Was the ICD going to be injured, which had been some of the questions in the past? Right. And what were the increased risk of having an arrhythmic event or shock during a sporting event? What did you find?
Well, we were curious as to just how many events we'd have. And at the end of the study, we had 70 athletes who had had shocks, and they had 120 shocks or so during the study. And the shocks were mostly due to ventricular tachycardia. We had every electrogram from the device firing analyzed. Most were due to VT. There was some SVT, as you'd expect, and there was very little just spurious shocks due to noise, let's say. So the good news for us was that each patient was converted. and did not suffer ill effects. Neither the process of being shocked itself or failure to shock did not become a problem.
Okay.
And they all survived their brush with potentially lethal arrhythmia.
So that's important. So it proved that they survived that. And then I think importantly, you also certainly looked at when did these events occur? Did they occur during sports as much as other places?
Well, it's a very good question. That's the key question. Most occurred during sports. And others occurred during what we called getting ready to do sports, activity that wasn't their basketball game. Let's say they were in practice. And the vast majority were in one of those two categories. Okay. Very few occurred at rest.
So that sounds like some very encouraging results in that aspect. What about the risks of the device? Did they wear down faster? Did they have lead fractures? Well,
we were very concerned about lead fractures. And so we kept close tab on lead fractures. And one of the things we recommended to the young people, particularly the basketball players, was that they telemeter their lead impedance to us after each basketball game. We saw lead fractures, but it wasn't at any more prevalent rate than a lead fracture that a 50-year-old would have in a normal, non-athletic existence. So that concern, fortunately, we didn't find in this study.
So it looked like it was safe as far as the device. And there were arrhythmias, as you might predict, but no fatal arrhythmias. Is there a particular subgroup that out of that you were worried about? Is there, within this group of 370, is there, ICDs are put in for lots of reasons. Was there a group that we ought to really pause about?
That's a very good question. We looked at the group that had more than one shock to convert their ventricular tachycardia. There were 7 of them, and 4 of them required 6 shocks, which isn't optimal, obviously. We have records of all of those, and some of them are quite hair-raising when you look at them. None, of course, as I said, died. But these were limited to 3 categories of patients. First group is arrhythmogenic right ventricular dysplasia, a particularly troublesome group of patients to take care of in terms of athletics. The second group was coronary patients who I think must have become unstable. The average coronary patient doesn't go into VT unless he or she's ischemic. And then CBVT, catecholamine-allergic polymorphic ventricular tachycardia, was the third category. And those patients, I think, really need to be excluded from this formula for protection. We had a lot of shocks for very few patients in that group. So I'd say definitely the ARVD patients and the CPVT patients, you ought to think twice about allowing them to participate. And we're trying to get studies to look at them more carefully and how we might manage them more carefully. But right now, I think both Rachel and I would say they don't fall into this category of patient that would be given a green flag to go and participate in sports.
So very useful information, and it sounds like this registry really may have shifted the curve and given us some real data that we can more confidently advise our ICD patients with the 2 or 3 caveats you've mentioned.
Well, there's data now. It's not just 1 or 2 electrophysiologists thinking that they've got the answer. And I will say, having thought about this a good bit, that I don't think we're going to have another data set like this. This is very tough to do. The funding sources for this kind of research, I think, are disappearing. And we'll see how the next Bethesda Writing Committee deals with this. But I think it gives guidance and gives an opening for the electrophysiologist or cardiologist that wants to give his or her athlete population a second chance to participate in sports.
Great. Well, thank you very much.
Thank you.